So let's cover the stations of examination part on the shoulder. So first of all, let's see about the shoulder, rotator cuff tear or frozen shoulder. So how are the stations? 52-year man James injured left shoulder 5 weeks ago after slipping performed to focus examination. So on inspection, you have to check for muscle wasting, asymmetry, swelling, bruising, winging of the scapula, posture, then palpation, palpate, temperature, tenderness, clavicular joint, clavicle, clavicular joint, acromion, bicipital groove, scapula. Then positive findings, tenderness of supraspinatus insertion, look for the clavicular joint, bicipital groove, tenderness and all that. Then movements, active movements you have to do for shoulder, external rotation, abduction. So both these can be done by hands behind the head and elbow by the side. So there it will be doing abduction, external rotation, internal rotation, adduction, external behind, flexion, extension. So abduction, raise the arc, external rotation, internal rotation. So passive movement we have to do. Then special test, Jobs NT-CAN test. So this is done to detect supraspinatus muscle tear, weak and painful arc, impingement, infraspinatus muscle external rotation, lift off test subscapularis, external rotation lag, drop arm test, unable to smoothly lower the arm, Hawkins Canadian Nears test. The neurovascular examination of the sensation over the deltoid, axillary nerve and distal pulse. The summary, you have to see that 52-year man, signs suggestive consistent with the left shoulder cuff pathology, mostly supraspinous tear, as well as impingement following fall 5 weeks ago. Finding include mild supraspinous wasting, localized tenderness, painful arc, decreased active, weak flexion, and the Jobs test is positive. You have to say about the positive test overall. Then most likely questions is supraspinal tears, it's secondary. What are the most likely diagnosis? What are differential rotator cuff tear, subacromion bursitis or acromion impingement, acromoclavicular joint pathology, less likely adhesive capsulitis by tendinopathy. What investigations? X-ray shoulder, exclude the fracture, USG, assess the rotator cuff tear, MRI is the gold standard, define tear size, retraction help. Management is initially analgesics, NSAIDs, physiotherapy, steroid injection. Surgery if full thickness tear, significant weakness. Distinguish rotator cuff tear and adhesive capsulitis. Range of movement is preserved. Nerve, axillary nerve, sensation over the deltoid, subscapular nerve, supraspinatus muscle and infraspinatus weakness. Long thoracic nerve, winging of scapula. Suggestion of full thickness tear, positive drop arm, inability to initiate. Then muscle wasting. So this was about the shoulder rotator cuff tear. And what about the frozen shoulder? 55-year-old man, history of progressive stiffness and severe pain, left shoulder, type 2 diabetes. So no obvious wasting is there. In late stage is positive, no deformity, swelling and bruising. Patient holds slightly, avoid the movements. So on palpation there is no tenderness, no warmth, no swelling, no focal lesion. The movements will be global restriction of the movement, both active and passive due to stiffness, capsular pattern, external rotation, most probably external rotation is restricted, abduction next, then internal rotation. Rotator cuff testing difficult to assess due to stiffness. Impingement less reliable. Drop arm test is negative. Nears, Hawkins not reliable. Hallmark is passive, range is lost. So summary: 55-year-old woman, signs left frozen shoulder, adhesive capsulitis, 4-month history of progressive stiffness, underlying diabetes. Findings include no swelling, bruising, and no global restriction of the movements. So questions are most likely diagnosis capsulitis, rotator cuff tears, pathology of frozen shoulder, idiopathic, insidious, painful, inflammatory conditions, cause fibrosis, glenohumeral joint, causes primary, idiopathic, secondary diabetes, hypertensive, post-surgery, trauma, stages, freezing initially, painful, gradual 3 to 9 months, frozen, prominent stiffness, thawing, recovery. How diagnosed? Clinical, imaging, X-ray, MRI, joint, conservative physiotherapy, NSAID, steroids, manipulation under anesthesia, orthosis, capsule release. So that about the hand, you get a middle-aged man, left hand deformity and numbness. Expose the hand, palm, dorsum, claw, ape hand, muscle wasting, thinner, hypothinner, skin changes, scar, ulcer, nail changes, tremors, asked, do you have any pain or tenderness here? Palpate thenar, hypothenar joints, and then carpal tunnel, Giles canal. Motor nerve, median nerve. The function has to be thumb opposition and abduction. Ulnar nerve, finger abduction, adduction. Fromet sign for the paper grip. Radial nerve, wrist extension, finger extension. Grade the strength. Then sensory, median nerve, palmar, thumb, index, and ring finger. Ulnar, palmar, dorsal, medial, lateral finger. Radial, dorsal, first wave. Special test, Tinel sign, phalanx test, Fromet sign, claw hand posture. Functional assessment, make the face, grip, examiner fingers, pick small objects, button the shirts, full neurovascular examination of per limb. Then inspection, summary, inspection, thin arm muscle wasting, tender carpal tunnel, motor weakness, abdominal grip, sensory, decreased sensation, and questions, carpal tunnel, diabetic neuropathy, cervical disc prolapse, high risk association, diabetes neuropathy, cervical disc prolapse, risk factors, carpal tunnel syndrome, non-modifiable, age, modifiable, obesity, pregnancy, vibrator, and CRF disease. Investigation, blood glucose, thyroid hormones, imaging, electrophysiology, nerve conduction studies, electrophysiological ultrasound, MRI. Treatment plan, treat the underlying disease, conservative management, risk splinting, NSAID, steroid injections into carpal tunnel, surgery, carpal tunnel release. So if you get a dependence contracture, visible flexure contracture, affected finger, palmar, skin puckering is there, palpation, fibrous cord in the palmar nodule, then tenderness, limited finger articulation, metacarpophalangeal and proximal interphalangeal tabletop test positive, grip strength is preserved, sensory is normal. Questions, benign fibro proliferative disorder of the palm nodules progressive with the cords. Risk factors, diabetes, tobacco, alcohol, age, trauma, family. Pathophysiology, fibroblasts, myofibrils produce collagen, extracellular matrix, flexion contraction, associated neurological claw hand deformity, connective tissue disorders, investigations, imaging, rarely rule out systemic disease. Treatment is non-operative splinting, physiological treatment, physical treatment, collagenase, injections, operative, unable to place hand flat, metacarpophalangeal more than 30 degree. So options are fasciotomy, dermatophysiotomy, common recurrence, long term up to 50%. The revision of the orthopedic knee, ankle, hip, foot, and spine. So as you have seen the stems for the knee, the person is having injury to the knee joint during the football, you do the inspection, palpation, then movements, active, passive movements, and the special test, neurovascular examination, then the questions. The special questions which are asked is, what can be the differential diagnosis? Medial, this can be most common diagnosis, anterior cruciate ligament tear, medial collateral ligament tear, cruciate injury, combination injury. Investigation, X-ray of the weight bearing joint, knee, MRI can be done. So what to look in MRI? There is increased signal intensity in menisci, abdominal meniscal shape. Next step in management is rise, rest, ice, compression, elevation, analgesic. Investigation, X-ray to rule out fracture, MRI gold standard. Then difference between anterior cruciate ligament injury and meniscal injury. So it is sudden, it is gradual, this is rapid, it is slow, this gives ways, usually is deep. And then when to refer the patient for the surgery, persistent instability, complication due to untreated, and then osteoarthritis, differential diagnosis, young rheumatic arthritis, old degenerative, gout, and pseudogout. What is the difference? The gout in the small joints, pseudogout in the large joints, uric acid, calcium pyrophosphate in pseudogout. Then investigation, blood, foreign body, full blood count and inflammatory markers, imaging, X-ray finding is cone lesions. Then treatment is conservative and causes of TKR failure, infection, loosening, malalignment, patient can't walk, treatment plan is surgery. So for the ankle, you get an injury to the football player, ankle showing exposed both the ankle, then do all the inspection, palpation, movements, tenderness. As I have shown this neurovascular examination, what is the summary? So you have to say the positive findings, then what are the questions? So most likely diagnosis, anterior talofibular riband sprain, differential diagnosis, fracture lateral malleolus, then fracture fifth metatarsal, cuboid fracture, tibiofemoral fracture. Gait is antalgic, Then medial and lateral ligaments. So medial side there is a deltoid ligament, and lateral is anterior tibiofibular ligament, posterior tibiofibular, calcaneofibular ligament. So fibular ligament, and this is on the medial side, anterior tibiotalar, deep posterior tibiotalar, tibionavicular, tibiocalcaneal. Grades of ankle sprain: one is mild, no instability; moderate, partial care; third is severe grade. The management: first line is RICE, NACIT is functional bracing, X-ray showed undisplaced fracture fibula and ankle. Management is RICE. Weber's classification: A, B, C. A is conservative, weight bearing, tolerated, Webat in the boot. B is surgery, trans, and C is also surgery. Then how to prevent injury in future: warm up and strengthening exercises, balance proprioception, strengthening exercises, ankle stabilizing, use ankle supports for the athletes. So for the hip joint, 75-year-old man, you do exposure, then see the inspection, palpation, movements, active, passive, special test, leg length, tendon test, then the summary. And what are the questions? What is the differential diagnosis for the hip joint: fracture neck femur, intertrochanteric fracture, hip osteoarthropathy, lumbar pain referred. Management is ortho reference, surgical fixation, hemiarthroplasty, THR, analgesic, DVT prophylaxis. Complication: avascular necrosis, DVT. If osteopathy inspection, no leg shortening, external rotation or inspection. If osteoarthritis, there will be no leg shortening, mild swelling, muscle wasting, palpation, generalized tenderness around the joint line, no bony deformity, global restriction movements. Leg length, apparent shortening, tendon bud test, special test. Summary: muscle wasting, hip, generalized tenderness, global restriction of the movements, no acute deformity. Then the differential diagnosis is same as above. Investigations: cone lesions. Management: conservative, surgery is THR. Complications of disability. Then causes of tendon bug: gait, superficial gluteal nerve injury, missed fracture neck femur, gait, tendon bug test, waddling gait, antalgic gait, high stepping gait. These are different gaits. So for the foot, you get 30-year male underwent radiofiber ablation, then ask the patient to walk, look for high stepping gait, toe dragging, use for the splints, postures, palpation, common femoral and the neck and fibula, calf, anterior compartment of facing tone. Ask, do you have any pain? Motor, ankle dorsiflexion. So motor examination: ankle dorsiflexion, tibialis anterior, deep peroneal nerve, total extensor distal longus, deep peroneal lung. Foot eversion, superficial peroneal. Compare the sides: sensory, dorsum of the foot, superficial peroneal, first wave, deep peroneal, lateral leg, superficial peroneal reflexes, ankle jerk, S1, knee jerk, L3, 4. Then the summary: assess the hip and the summary inspection, visible foot drop, muscle wasting, scar, RFA site, palpation, tenderness, fibular neck, motor weakness in the dorsiflexion, weak foot reversion, sensory decreased sensation, dorsum of the foot, first wave affected. Questions are: common peroneal nerve injury, posterior ablation, differential common peroneal radiculopathy, sciatic nerve injury, stroke, upper motor neural lesion, motor neuron disease, peripheral neuropathy. Other causes of common peroneal injury: fracture neck femur, prolonged tight plaster, dislocation of knee joint, common weakness in the dorsiflexion, weakness in the extension, weak foot eversion, sensory loss, dorsum of the foot. Clinical picture: central causes, positive Babinski sign. How do we differentiate between common peroneal palsy, radiculopathy, peroneal weak dorsiflexion, sensory nerve deformity, lateral ligament? L5 root: weak dorsiflexion plus sensory loss, lateral thigh, leg preserved pressure. Spine, back pain. Investigation: nerve conduction studies, electromyography, MRI spine, ultrasound of nerve if entrapment, blood glucose. Management plan: physiotherapy, ankle, foot, analgesics. Treatment: underlying cause, complications of underfoot drop, nerve repair, contractility, disability, no obstruction, active against the. So then this was about spine. So bilateral lower limb pain, difficulty in walking, pain and heaviness in the legs after walking short distance, relieved by sitting. I will be examining your spine and assess the movement, then the gait, patient was inspection, patient standing, expose the spine, posture, alignment, scoliosis, palpation, spinous process, paraspinous movements, flexion, extension, lateral rotation, neurological hip flexion, knee extension, ankle, and all this you do. Lumbar disc herniation, you are suspecting, then you differential peripheral vascular disease, lumbar stenosis, spondylosis, Then you have to think of investigations like MRI, lumbar spine, gold spot, X-ray, spine, spondylolisthesis, generative changes, CT, myelogram, MRI findings, narrow spinal canal, hypertrophy of ligamentum flame, disc bulge, fascial joint orthoplasty. Next step in management is initial analgesics, physiotherapy, modify activity, deformity, supervised exercise, steroids, decompression, laminectomy, claudication. What is difference between neurologic and vascular? Worst by extension, relieved by flexion. Normal ABPI, reproduce by the extension. When to refer to surgery? Persistent deafening, claudication, despite considered treatment, neurological deficits, severe impact, quality of life, complications of untreated spinal stenosis, progressive neurological deficit, chronic pain and disability and mobility and independent, lumbar tumors, ependymoma, neurofibroma, meningioma, schwannoma, extradural mets. So this was about